Yes, somebody from Three Dots is here. आनंद जी, आनंद जी,
जी जी, गुड इवनिंग मैम।
गुड इवनिंग। हाँ जी, सर से बात हुई है?
सर से अच्छा, ये 7:20 पे उन्होंने मैसेज किया था कि ये लिंक जो है सेम फैकल्टी और इसके लिए, तो हम बोले हाँ तो ठीक है, बोले ओके। उसके बाद अभी फोन भी किए तो फोन नहीं रिसीव किया वो।
अच्छा ठीक है,
जी
ठीक है, ज्वाइन कर रहे होंगे, ही मस्ट बी सेटिंग अप।
जी जी।
ठीक है। गुड इवनिंग सर। Can you hear me, sir? You, you're on mute, sir. You have to unmute yourself.
Sorry. Yeah. Am I audible now?
Yeah, you're audible. So, good evening, sir. I'm Dr. Shraddha Ranjan. I'll be moderating your session.
All right. Thank you.
So, I think we are right on time. We are 5 minutes late. आनंद जी, शुरू करें अभी? कितने लोग ज्वाइन किए हैं?
नहीं, यस मैम, आप स्टार्ट कर सकती हैं।
हाँ, हम
अभी
लोग स्टार्ट करते हैं।
जी जी।
So, good evening, all our students. So, we'll be starting our program, which is being done every Friday. Cardiology classes are being taken care of. And today I'm happy to invite Dr. Ravi Kirti sir. He's Professor General Medicine in All India Institute of Medical Sciences, Patna. He comes along with a great deal of experience. And today he'll be taking a very important class on heart failure, clinical aspects, which would be really helpful for you people in your clinical practice, in your wards and everywhere. So, sir, over to you.
Thank you, Dr. Ranjan, for such a kind introduction. And at the outset, I would like to thank the Indian College of Physicians for having invited me to talk on this very important topic. And especially, I mean, it's talking to young doctors is something that I always look forward to. So I hope this will be useful to them. Let me bring up my slides. Sorry,
There's a you have to open your PowerPoint, and below there will be an option of share. Can you
yeah,
see
but
it? Hmm.
when I went there, it said I will need to change my system settings. Can I
Oh,
just give me?
yeah,
I'll
sure,
log
sure,
come back again. Yeah.
sure. It will be in privacy settings somewhere. You will
Uh,
have to allow screen sharing. It will be something like that. In your settings, privacy, there allow screen share.
okay.
Yeah, just try that.
And this thing has also gone small. I can't get full screen somehow. Uh,
You can log out, sir. And
Yeah.
just in the meantime, we'll be talking with the students.
Okay.
There is some technical glitch. It's okay. So we'll be back soon, I hope. So in the meantime, the people who have joined us, can you just unmute yourself and give your introduction, or in the chat box you can give your introduction, and let's start discussing. What do you mean by heart failure? How do you define heart failure? Anybody volunteer in the chat box? Dr. Neha, you have sent a hello in the chat box. So just tell me cardinal symptoms of heart failure. Anything?
Ma'am, can I tell?
Yeah, sure. Anybody?
I'm Dr. Yasmin. I feel heart failure is, by definition, is inability of the heart to contract and eject a certain part of the end diastolic volume, or fill completely, relax completely and fill. So we have two types of heart failure: systolic heart failure and diastolic heart failure.
Good. So if you want to make it more simple, you can just say that an inability to maintain cardiac output. So that will be and you're right, there are two types. We'll be discussing about it. Sir has joined and we can see his screen as well. So I think we'll be starting soon. So Dr. Yasmin, thank you for sharing.
Thank you, ma'am.
So you have to unmute, sir. You're again on mute, but we can see your screen.
And
Yeah.
you can see my screen now.
Yeah, definitely.
Okay, great.
So we can put it on PowerPoint mode and
Yeah, one sec. I just.
share.
Right. So once again, very good evening to all of you. I've been asked to speak on the clinical aspects of heart failure. So basically in this class, we will be, the objective of this class is that at the end of the session, all the trainees should be able to recognize heart failure from the clinical presentation in a majority of cases, and they should be able to outline the evidence-based management of heart failure. So as you can see, my expectations are very modest because I don't think that after attending an online class, one would be very proficient in managing all cases of heart failure. It's something that we have to learn by seeing patients and at the same time upgrading our clinical and theoretical knowledge. But I am very optimistic that when you go home after this session, you will, I will at least have reinforced some of the good things that you're already doing, and you will hopefully learn a few things as well. So how do we define heart failure? So this is the definition that has been forwarded by the American Heart Association. It's a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood, leading to the cardinal manifestations of dyspnea, fatigue, and fluid retention. So as you were discussing, I think one of the participants was mentioning diastolic and systolic heart failure. So basically, if there is a problem in the filling of the ventricle, that is what we have been traditionally calling diastolic heart failure. And on the other hand, if the heart is failing as a pump, if the pumping action is missing and it is unable to eject sufficient amount of blood out of the ventricle, that is what we have traditionally called systolic heart failure. So this is just one of the definitions. There are many definitions, but the important things to remember is that there is some structural or functional problem which either interferes with ventricular filling or ejection of blood, or sometimes both. And this leads to the typical clinical features of heart failure, the most important ones being dyspnea, fatigue, and fluid retention. Now, why is it important to learn about heart failure? So just some facts and figures. Globally, 26 million people are affected by heart failure. And this goes up as the population ages. And therefore, even in India, in times to come, we are going to see more and more cases of heart failure. 12% of adults above the age of 80 have heart failure. We do not know the exact incidence and prevalence in India, but it is estimated that the incidence is between 500,000 to 1.8 million per year. So that means these many new cases are added every year in India. So fair enough, it's common, but flu is common, headaches are common, migraine is common. So what's special about heart failure? Well, it's not only common, it's also a pretty serious condition. Overall 5-year survival following diagnosis is about 50%, and this is in primary care. For patients who get admitted with heart failure, the 5-year mortality approaches 75%. So it's a pretty serious condition. And it also has a significant economic implication, because not only the cost of treatment, but also in terms of the time lost and lost to work, etc. The economic burden is huge. And in 2012, it was estimated that the global economic loss would be about 108 billion. And that was 12, 13 years ago. Fair enough. So it's common and it's very serious. Even then, I'm not convinced I really need to know much about heart failure. Well, the good thing is the overall prognosis is improving, and that's because of good management of the etiological factors, comorbidities, and evidence-based management of heart failure. So not only is it common, and not only is it a pretty serious condition, but there is a lot we can do about these patients. There is effective evidence-based treatment available, and that is why it is important to familiarize ourselves with this condition and how to best manage it. Now, there are many ways in which heart failure can be classified. So For example, we were discussing diastolic and systolic heart failure. Historically, we have used many kinds of classifications. You can have backward and forward heart failure. Backward meaning congestion in lungs and in the rest of the body. Forward heart failure meaning symptoms of hypoperfusion like fatigue or in the elderly confusion, etc. You can have an acute presentation of heart failure, and you can have chronic heart failure or congestive heart failure. You can have left-sided heart failure, which would present typically with pulmonary edema, and you can have a right-sided heart failure, which would present with peripheral edema, pleural effusion, raised JVP, hepatomegaly, etc. But from a clinical perspective, it is, from the perspective of managing heart failure, the most important classification these days is heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Now, this would roughly equate to systolic and diastolic heart failure, but they're not exactly synonymous. So reduced ejection fraction means that the heart is not able to pump effectively. There is systolic dysfunction mostly. Whereas heart failure with preserved ejection fraction means that the ability of the heart to pump blood is still preserved. However, there is insufficient filling of the ventricles, and that is why there is the typical signs and symptoms of heart failure. In between, there is this category, heart failure with mid-range ejection fraction, or earlier it used to be called heart failure with mildly reduced ejection fraction. There's no point arguing about the exact nomenclature. Basically, this is a subset of patients that lies between these two extremes or prototypes, that is heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So when the ejection fraction is more than 50%, we call it heart failure with preserved ejection fraction. When it is less than 40%, we call it heart failure with reduced ejection fraction. And in between, we call it heart failure with mid-range ejection fraction. So heart failure may present with, a patient may present with chronic symptoms of fatigue, dyspnea, pedal edema, etc., or there might be an acute presentation. Most patients who present acutely have underlying chronic heart failure, and something has triggered their symptoms, and they end up in the emergency with acute decompensated heart failure. However, about 20% of all presentations with acute decompensated heart failure or acute heart failure may be new, and that might have been triggered by some event like myocardial infarction or a new arrhythmia, etc. Am I clear so far? Any questions? Okay.
Yes, you can ask your questions, but I think, sir, you have explained it quite nicely and very slowly also, so that everybody should understand. And this is the, okay, sir.
So now, what are the causes of heart failure? So on the left side of the screen, you see causes of heart failure with reduced ejection fraction, and on the right side, you see causes of heart failure with preserved ejection fraction. Having said that, there might be significant overlap, and conditions that have been listed in one column may also present with features of the other group. So heart failure with reduced ejection fraction, the common causes are coronary artery disease, which may be myocardial infarction or chronic ischemic cardiomyopathy. Valvular heart disease, especially aortic stenosis, aortic regurgitation, mitral regurgitation, and tricuspid regurgitation. Certain congenital heart diseases may also present later on in adulthood, sometimes for the first time and sometimes because they have not been adequately managed in childhood, or they were managed but still they have now presented with complication in the form of heart failure. Dilated cardiomyopathy, again, that might be because of various reasons, including coronary artery disease, alcohol, certain drugs, chemotherapy. Pulmonary arterial hypertension may progress to cor pulmonale and right-sided heart failure. HIV is an infective condition. Certain connective tissue diseases like SLE may present with myocarditis, leading to heart failure with reduced ejection fraction. On the other hand, conditions that lead to hypertrophy of the heart muscles often result in inadequate filling. So hypertension and valvular heart disease like aortic stenosis, hypertrophic cardiomyopathy, these are all conditions where the actual volume of the cavity is reduced, thereby impairing the filling of the heart. Mitral stenosis, the problem is upstream, as you can see. So basically not enough blood is able to reach the left ventricle because of the stenosis. Similarly, there are conditions where the heart is not able to relax adequately, and this includes restrictive cardiomyopathy and constrictive pericarditis. Myocarditis, viral myocarditis, typically presents with, or even postpartum myocarditis, typically presents with heart failure with preserved ejection fraction, but sometimes they may also have present with heart failure with reduced ejection fraction. Radiation, aging, obesity, these are some of the other causes. Now, how do these patients present? So shortness of breath, as that is mainly because of pulmonary congestion and pulmonary edema. Orthopnea and PND, these are very characteristic features of heart failure. So you should be able to take a proper history, and you should know how to ask patients in the local language whether they have these symptoms of orthopnea and PND. And that is an art, that is something that you must practice. So you have to ask them whether their breathing gets worse when they lie supine, and whether they have to wake up at night feeling breathless when they sit up with their on the edge of the bed and go to the window, and it might take up to half an hour for the breathlessness to settle down. That is typical paroxysmal nocturnal dyspnea. The shortness of breath is typically worse on exertion, and as the disease progresses, as the symptoms worse, the exercise capacity of the patient reduces, and in New York Heart Association classification class 4, patients might be breathless even at rest. And when they have a history of exertional breathlessness, you should also try and quantify their exercise tolerance. So you should ask how far they can walk before they have to catch their breath. Then weight gain, ankle swelling, abdominal bloating, anorexia, early satiety, right quadrant discomfort. These are all features of right-sided heart failure. So basically because of fluid accumulation in the body. Early satiety, anorexia, that is usually because of gut edema, and right quadrant discomfort because of the liver enlargement. All of these are features of congestion, whereas fatigue, weakness, these are features of hypoperfusion, because the heart is not able to pump effectively, and the body does not get sufficient blood supply and oxygen. So the patient may complain of fatigue and weakness. The elderly who have cerebrovascular disease, they might just be dull and confused. And also these patients usually have poor sleep. That might be because of various reasons. As we have seen, these patients have orthopnea and PND, chain stroke breathing, and central sleep apnea. They are also seen quite often in patients with heart failure. If they are on diuretics, they might have to wake up during the night to relieve themselves. So generally, these patients also have poor sleep. Now, if you were to examine these patients, typically the patient would be sitting. They don't like to lie down. They would look anxious, sweaty, and dyspneic. Now, this is an extreme presentation. Not all patients would be as dyspneic, and sometimes they may actually look quite comfortable at rest. It is only when they start exerting that they become dyspneic and tachypneic. Again, a patient, the patients may have pallor. Anemia is quite common in heart failure because of various reasons. If the patient is hypoxic, there might be peripheral cyanosis, cool extremities. Because of hepatic congestion, they might have icterus, edema, obviously, feature of fluid overload. Cachexia is also common, and this is for various reasons. One is obviously malnutrition. The patients have poor appetite. Absorption is poor because of gut edema, and because they do not exercise sufficiently, so there is loss of muscle bulk. Typically, you would see temporal hollowing and loss of muscle mass in the upper half of the body. Usually these patients have tachycardia, and sometimes if you feel their pulse, you can feel that the pulses have, the pulse volume varies from pulse to pulse, beat to beat, and there might be alternating pulses with good volume and not so good volume, something that is described as pulsus alternans. Tachypnea, chain stroke breathing, we have discussed these. And if you were to examine them, especially if there is right-sided heart failure, the JVP would be raised. If you were to auscultate their lungs, bibasal rales is typically what you find. So rales, crepitation, creps, crackles, these are all synonymous. So don't get confused. So bibasal crepitation is typically what we see. And as the pulmonary edema worsens, you might get crepitations even in the upper, higher up in the lungs. On auscultation of the heart or on examination of the heart, the apex may be displaced outwards and downwards if the ventricles are dilated. If there is right ventricular hypertrophy, then you might find a parasternal heave. Third heart sounds is often found in patients with heart failures, and tachycardia along with third heart sound is what gives rise to the typical gallop rhythm, as if you might have seen in old movies, horses galloping, that typical sound, tuck, 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 tuck. That is something that you can appreciate sometimes in patients with inadequately managed heart failure. You might hear if the underlying there's any underlying structural heart disease, you might hear murmurs. On the examination of the abdomen, the liver may be enlarged, might be tender, because of the capsular stretching, and there might be ascites also. If the ascites is the most prominent finding in a patient, then you should consider other differentials like cirrhosis of liver. Sometimes constrictive pericarditis can present primarily with ascites. Jugular venous pressure, I know all of you know how to do this, but just a quick reminder, the patient should lie at an angle of 45 degrees. And you have to identify the highest point of jugular venous pulsation and then measure the vertical distance from the sternal angle up to that highest point. And then you have to add 5 centimeters more, and that would give you the exact JVP. Having said that, in clinical practice, I wouldn't bother too much trying to measure the exact JVP, because you do not take actions based on the exact measurement. And moreover, I know that in examination you use scales or rulers to measure it, but those methods are very inaccurate and never give you the right measurement. So all that matters is that you should be able to identify patients with raised JVP. And you can use familiar landmarks like so many centimeters above the clavicle or up at the angle of the jaw or behind the ear lobule. If you use those descriptive terms in clinical practice, that is good enough. But you must know the principle of measuring the JVP, which is what we have just shown here. Now, you know the NYHA classification. So class 1 is when the patient is able to do ordinary activity without any symptoms. So they're breathless only when they do unaccustomed or extraordinary activity. For example, running or climbing flights of stairs more than what they usually do. NYHA class 2 is when they are symptomatic with ordinary physical activity like climbing stairs or walking briskly. Class 3 is when they're symptomatic with less than ordinary physical activity, for example, just getting dressed, etc. And class 4 is when they are symptomatic at rest. Now, how do you investigate these patients? So in most patients, when they first present with features of heart failure, when you're suspecting heart failure, you should do these investigations, complete blood count, renal function, usually a metabolic panel, meaning blood sugar, liver function test, lipid profile. Coagulation, you might like to check for 2 reasons. One, because of hepatic congestion, the coagulation may be deranged, and sometimes you have to start these patients on anticoagulation, and you would like to know beforehand whether they have a normal coagulation to start with. Urinalysis is important because sometimes patients, for example, with nephrotic syndrome, may also present like heart failure because they might have pleural effusion, breathlessness, edema, etc. And sometimes because patients with diabetes are overrepresented amongst patients with heart failure, and diabetes might also lead to proteinuria. So urinalysis is always helpful. These days, we use biomarkers like BNP or NT-proBNP that aids in diagnosis, usually very sensitive. Obesity is one reason where you might find falsely negative BNP or pro-BNP results, but usually they are very sensitive. Of course, we would do an ECG in most patients and a chest X-ray. But the diagnosis is usually confirmed by cardiac imaging in the form of a 2D echocardiogram. There are other methods of imaging also available. For example, an MRI might give you a much better picture, but one, there is lack of availability, there's cost involved, and you really need people who are very good at reporting cardiac MRIs. So the question you should ask yourself is it actually going to change the management? It might change the management in some patients where you are suspecting, say, an infiltrative disease like sarcoidosis or hemochromatosis, etc. And these might be better identified on MRI. But for all practical purposes, we use echocardiograms as the non-invasive imaging of choice for diagnosing heart failure, both for diagnosing heart failure as well as for identifying the cause of heart failure in a given patient. So this is a typical chest X-ray. Would anyone like to describe this?
Come on, Dr. Yasmin, Dr. Neha. Just these all the classical findings of heart failure are there. If you can just recollect theory, then also it will be enough. And what we can see in the X-ray? Anybody volunteer?
Okay, so I mean, yeah, so as you said, this is a very classical X-ray of pulmonary edema. You can see what looks like a pacemaker there. But talking about the lungs, you can see prominence of the upper lobe vessels. There is perihilar congestion on either side, and you can see these lines, these reticular markings, which is because of the interstitial fluid. So this is what a typical pulmonary edema would look like. So this has been taken from European Society of Cardiology. So this is a diagnostic algorithm for heart failure. So when you suspect heart failure on the basis of signs, symptoms, risk factors, and a normal ECG, then these days we are advised to use the biomarkers NT-proBNP or BNP. Use your local cutoffs. Your lab might be using different units, different cutoffs, etc. So you should use your own cutoffs. So if they are normal, they are not elevated, then heart failure is unlikely, and then you look for other diagnosis. On the other hand, if NT-proBNP or BNP level is raised, then heart failure, and you have been suspecting heart failure, then you should go ahead with an echocardiography. If the finding is, again, if echocardiogram is completely normal, then heart failure is unlikely and you look for other diagnosis. But if it is abnormal, it confirms heart failure. Now you have to classify it depending on the ejection fraction into, as we have discussed earlier, heart failure with reduced ejection fraction, heart failure with mid-range ejection fraction, or heart failure with preserved ejection fraction. And then you go ahead to determine the etiology and start treatment. So I hope it is clear. Now let us look at a case scenario. Here I would really want someone to volunteer themselves. So a 64-year male smoker with no significant past medical history presents to a district hospital with a 2-hour history of acute breathlessness and chest discomfort. On examination, the blood pressure is 166/90. Saturation is 90% on room air. The patient looks anxious and sweaty. JVP is normal. There's no peripheral edema. Heart sounds are normal, but there is the presence of bibasal crepitations. So what are we thinking of here? Let's speak out loud, please.
Yes. Somebody volunteer. If you're too shy to speak, you can write in the chat box. I'll convey. But you should volunteer. Huh? You're getting such a good class in the comfort of your rooms. Don't sleep. Somebody has said cor pulmonale. So don't jump to diagnosis. Just try to.
Said ACS, which might be true. Cor pulmonale, well, we don't have any features of right-sided heart failure here. JVP is not raised, there's no edema, so, and there's no previous history mentioned of any underlying lung condition. Acute heart failure, yeah, okay. So what would you like to do? Yeah, so all the right answers or right looking answers are coming up in the chat box. So what would you like to do now? ECG. Okay, Dr. Gohil, we will do an ECG for you. So what do you see there?
Come on. What is this? ECG? ST elevation and what leads? So somebody said it's an anterior MI.
Yeah, okay. So yeah, anterolateral MI, yeah, involving many of the leads really. So it must be a very big one.
Big one.
So what are you going to do? And this is the X-ray. So again, typical of heart failure, the cardiac stellate is enlarged. I'm sure all of you know how to calculate the cardiothoracic ratio, which is you take the maximum cardiac diameter, that is from the midline, you take the maximum diameter to either side, add them up, and then the result is divided by the maximum thoracic diameter. And if it is more than 0.5, that is suggestive of cardiac enlargement. And you can see some bilateral congestive changes, which is in keeping with our diagnosis of heart failure. So how are we going to manage this patient? Any suggestions, please? So yeah, all of you have said anterior wall MI. So diuretics, okay? So yes, you're right. The patient needs to be decongested. We would give them diuretics, beta blockers, okay, but maybe not immediately because they have features of decompensated heart failure. Of course, dual antiplatelet, and what else? Enoxaparin, okay? PCI. Right. Okay, I think we have got all the right answers. So let's move on. So let's talk about the treatment of acute decompensated heart failure first. So the goals of treatment are hemodynamic stabilization and decongestion, identification and treatment of any precipitating factor. So for example, in this case, the precipitating factor was MI, as all of you rightly picked up. So we would need to address that. And then once we have done the initial stabilization and decongestion, we need to shift them to long-term care. So long-term treatment has to be started. And what usually precipitates acute decompensation? So these are some of the causes on the right side. So excess fluid or sodium intake, or if they have exerted more than what they are used to, there's some emotional stress, they have been missing their treatment, heavy alcohol intake, certain drugs like non-steroidal anti-inflammatory drugs, or calcium channel blockers like diltiazem or verapamil, because they are very strongly negatively inotropic. They can precipitate heart failure. Uncontrolled hypertension, acute coronary syndrome, any atrial or ventricular arrhythmia. Then systemic conditions like sepsis, anemia, hyperthyroidism, these are all high output states. Pulmonary embolism may occasionally precipitate heart failure. These are all the causes that precipitate an acute attack. And how are we going to manage? So as you know, we have to keep them propped up and give them supplemental oxygen, try and keep the saturation between 94 to 98. And then decongestion with IV loop diuretics. So typically we would use furosemide. The dose range would be from 20 milligrams to 240 milligrams in a day. Typically, we would start with 40 milligrams stat, IV stat, and then thereafter maybe BT, but we can titrate it up and down. You might have problem if the patient is hypotensive, that is, the patient is in cardiogenic shock or going into cardiogenic shock. Then using diuretics might be a problem because they would lower down the blood pressure. And believe me, cardiogenic shock is a very difficult condition to treat and with very high in-hospital mortality. But otherwise, if they have good blood pressure, give them IV loop diuretics. As I said, you can typically start with furosemide 40 milligrams statin twice daily, build up on the dose. Sometimes if they cannot tolerate higher doses, but you have suboptimal response, you can even give them a continuous infusion of the same dose, which might be better tolerated. The other thing that you can do, again, if your blood pressure allows, is use a vasodilators like intravenous nitroglycerin. So you can use a GTN infusion, for example. It is given as a continuous IV infusion. Initially, you have to start with 5 to 10 micrograms per minute, and then you have to titrate it as needed based on the patient's response, as well as tolerability mainly in terms of blood pressure. So you will have to stop it if the systolic blood pressure goes below 100. So you start with a dose of 5 to 10 micrograms per minute, and you can keep increasing it every 5 minutes up to a maximum of 200 micrograms per minute, depending on tolerability and the need. Non-invasive ventilation is another thing that can be helpful in patients with pulmonary edema. You can use both CPAP and BiPAP. So typically you can start them on just give them CPAP, a PEEP of, let's say, 5 centimeters of water, and if tolerated, go up to 7.5 or maybe 10 centimeters. Again, there might be issues in terms of tolerability. Many patients would not like to have a tight-fitting mask on their face. And the other thing is NIV can also, to some extent, lower the blood pressure. You can also use BiPAP, and especially if they have type 2 respiratory failure, which means that they're not only they are hypoxic, but their partial pressure of carbon dioxide is also elevated. In that case, you can use a BiPAP. For example, you might start with expiratory pressure of 5 centimeters and a inspiratory pressure of 10 or 12, and then build up on the inspiratory pressure depending on the patient's tolerability. It usually gives very good results in the acute setting. The only problem might be tolerability. And of course, if the patients are hypotensive, as I said, it's very difficult to manage these patients. That's when you would use vasopressors. These days, the treatment has been simplified. You do not need to know so many vasopressors or inotropes. Noradrenaline is being used. So you should familiarize yourself with the dosing of noradrenaline, and you can use it in patients who are hypotensive. So now coming back to the case. So the previously discussed patient was referred to a tertiary care center for primary PCI because, as you remember, we were sitting in a district hospital. So unfortunately, it took him 8 hours to reach the tertiary hospital. Then he had to wait for another 2 hours outside the emergency to find a bed. And altogether, there was a 12-hour delay from his initial presentation before he could reach the cath lab. Nonetheless, he underwent PCI and was discharged after 3 days. So you're seeing him again in the OPD of the district hospital 2 months later. Now he's breathless on walking 100 meters, and echocardiogram shows a large akinetic segment in the anterolateral wall with an ejection fraction of 38%. So what do we do now? And any comments?
What should have been done at the district hospital, or at least tried? Anybody? Nobody gave that answer, sir, in the management. That is the message of the whole.
Yeah, so these days, I know that PCI is much better than thrombolysis, but we must give a thought to the feasibility, and is the patient likely to get to a cath lab as soon as we would like them to be, and if not, it is always better to thrombolize them, and that is something that we must do in peripheral hospitals also. So nonetheless, now this patient has features of chronic heart failure. So how are we going to manage them? Manage this patient. So these are the different pharmacological agents that we use in the treatment of heart failure with reduced ejection fraction, as in this case. So we would use either an ACE inhibitor or an angiotensin receptor blocker or ARNI, one of these three agents. So traditionally, we have used ACE inhibitors or angiotensin receptor blockers because, as we know, the renin-angiotensin system is hyperactive, overactive in these patients. But these days, we are using ARNI, which is a combination of valsartan and sacubitril, which is something that basically potentiates the half-life of the natriuretic peptides. So a combination is now found to be better than just ACE inhibitors on their own. So you should be familiar with some of these drugs and know their doses properly. So for example, if you were giving them ramipril, you would typically start with a dose of 2.5 milligrams once a day. If you have concerns about their renal function, potassium, or the blood pressure is a bit borderline, you can start with a very small dose of 1.25 milligrams, and then you can gradually build up the dose. The target dose would be 10 milligrams a day. But then you have to give them as much as they can tolerate in terms of blood pressure, renal function, potassium, etc. As you know, these drugs cause hyperkalemia and sometimes they might lead to renal impairment. If you're using ARNI, then the starting dose is usually 100 milligrams BT, and then if they are well tolerated, you increase the dose to 200 milligrams BT. Again, the problem here is hypotension. And if you have started somebody on ACE inhibitors and or ARBs and now you are changing to ARNI, then you must give them a wash-off period of at least 36 hours before you start them back on ARNI. The next important drug is or group of drugs is beta blockers. So among the beta blockers, we use only 3 drugs in heart failure. They are carvedilol, bisoprolol, or a sustained release preparation of metoprolol. So you should know which one you like and you should know the dose properly. So while the effect of ACE inhibitors is a class effect, in the case of beta blockers, there are only certain beta blockers which are helpful in heart failure. So again, for example, if you were using bisoprolol, typically you would start with a dose of 2.5 milligrams a day and go up to a target dose of 10 milligram if well tolerated. If you are very cautious, if the blood pressure or heart rate is a bit borderline, then you can start with 1.25 milligrams. The other important thing to remember about beta blockers is that you only start them when you have decongested the patient, because if you start them during acute decompensation or while the patient is still decompensated, then it might worsen their symptoms, because beta blockers also have a negatively inotropic effect. And when you're not sure, start with a very teeny tiny dose and then build up gradually. The third important drug is mineralocorticoid receptor antagonist. All of you are familiar with spironolactone. Start with a small dose like 12.5 to 25 milligrams a day, and then go up to 25 to 50 milligrams a day. That would be the dose in heart failure. Of course, in portal hypertension and ascites, you use much higher doses, but for heart failure, the target dose is about 50 milligrams a day. The side effects, as you know, are hyperkalemia. Renal failure might be precipitated by any diuretic if we over-diurese any patient, and gynecomastia, you're aware. Gynecomastia is not seen with eplerenone. It's a relatively newer drug. Combination of hydralazine and nitrates. Personally, I don't use it, but this might be used when you're unable to use the usual drugs, ACE inhibitors or ARB or ARNI, because of renal failure or other problems. In that situation, you can use a combination of hydralazine and nitrates. Personally, I managed to put all my patients on at least some small dose of ACE inhibitor. But when you can't, you can use this combination. And lately, we have been using a lot of SGLT2 inhibitors, dapagliflozin, in patients with heart failure, definitely in patients with diabetes, but also in those patients who do not have diabetes. This drug is helpful. It works as a diuretic also, and overall in the long term, it has a beneficial effect. It is also renoprotective, as you know. So these are the drugs. Typically, I would try and place most of my patients on RAS inhibitor, a beta blocker, and a small dose of spironolactone plus minus SGLT2 inhibitor. Then there are a few other drugs which you should know. So this is a new drug, vericiguat. I haven't used it myself. It's a soluble guanylyl cyclase stimulator, and basically it increases the cyclic GMP level and leads to vasodilatation. So when patients are still symptomatic in spite of the usual treatment, then that's another drug that you can consider adding. Ivabradine is used only in a specific situation where the heart rate is still above 70 and you cannot go up on the beta blocker for whatever reason, usually because of lowish blood pressure. Ivabradine, and it is only used in patients who are in sinus rhythm. It would not work in patients who are in atrial fibrillation. So patients with heart failure in sinus rhythm and heart rate still above 70 in spite of using beta blockers, and you cannot go up further on the beta blocker dose, then ivabradine is something that you can consider. Typical starting dose would be 2.5 milligram BD. You can increase it up to 5 milligram BD. Digoxin again has very limited role. It is usually helpful in patients with heart failure and atrial fibrillation. But occasionally you might use it in sinus rhythm also. It has some positive inotropic effects. So if patients are still symptomatic in spite of standard treatment, then that's something you can consider. What else can we do? So obviously we need to manage the comorbidities and any precipitating factors. Among the precipitating factors, atrial fibrillation or other arrhythmias, especially atrial fibrillation, which is very common, that needs to be addressed. Anemia needs to be corrected. Any iron deficiency needs to be corrected. Even if the patients do not have anemia, but they have iron deficiency in terms of low ferritin levels, then give them IV iron. Cardiac resynchronization therapy or biventricular pacing. This is used in patients who are still symptomatic in spite of optimization of the medical treatment, and they have widened QRS complexes. So the QRS length is more than 160 milliseconds. These patients benefit from biventricular pacing or cardiac resynchronization therapy. Basically, what happens is the patients with heart failure, the contraction of the ventricular muscles is not very coordinated. So while one part is contracting, the other may not be. So biventricular pacing basically tries and restores the synchrony and thereby might help the symptoms. ICD implantation, anyone who has had any ventricular arrhythmia, who has had anyone who has had cardiac arrest due to any ventricular arrhythmia and they have been resuscitated back, or even primarily as a primary prophylaxis in patients with ejection fraction of less than 35% and symptomatic patients with an ejection fraction of less than 35 patients, ICD should be considered as it might prevent deaths due to ventricular arrhythmias. So this is a quick recap of what we have just said. So patients with reduced ejection fraction, the drugs that we should be using are ACE inhibitor or ARNI, beta blockers, potassium sparing diuretic, and dapagliflozin, that is SGLT2 inhibitors. These are the drugs that we should be using in most patients, and we should use loop diuretics for fluid retention. We have to decongest these patients. If we cannot manage with loop diuretics alone, then we can add a small dose of thiazide or thiazide-like diuretics also, although you have to carefully watch the renal function and electrolytes in such patients. Then, as we have said, if left ventricular ejection fraction is less than 35% and QRS duration is less than 130 milliseconds, then go for ICD. If patients are in sinus rhythm, ejection fraction is less than 35 seconds and QRS duration is prolonged, then CRT plus minus ICD. And if it is more than 35%, then device therapy is usually not indicated. You should continue with medical management. Now, just a quick slide on heart failure with preserved ejection fraction. Unfortunately, the treatment is mainly symptomatic, mainly in the form of decongestion. So use diuretics if they are in fluid retention. Try and correct the etiology if you can. And SGLT2 inhibitors like dapagliflozin are also used in patients with preserved ejection fraction. So with this, I would like to end. These are my take-home messages. Heart failure should be diagnosed based on clinical presentation, X-ray, biomarkers, and non-invasive imaging in the form of echocardiography. Underlying etiology, precipitating factors, and comorbidities should be identified and treated. The mainstay of treatment in patients with reduced ejection fraction consists of decongestion with diuretics, neurohormonal antagonism in the form of beta blockers and ACE inhibitors or ARNI, SGLT2 inhibitors. These are the important drugs to be used. And in patients with preserved ejection fraction, the drugs that we have are diuretics and SGLT2 inhibitors. And of course, treatment of etiological factors is warranted. So with that, I would finish my talk. If there are any questions, I would be happy to take them.
Thank you, sir, for the elaborate talk. And you covered everything so nicely. So that is the take-home message for the students, that clinically in the emergency, heart failure is kind of a systemic disease now. We know that it just doesn't affect the heart, it will affect your whole body. And as a medicine resident, you are in the best position to learn the nuances of heart failure, because it is the growing field. We are having so much, pharmaceutical drugs which are coming up and changing the whole landscape of heart failure management. So it is really interesting at this point of time. And sometimes in the emergency, you just have to know the, as such showed you, cardinal symptoms. If you recognize the heart failure, then you go along, try to get an echocardiography done to prove your findings, and then try to find out the cause. So that's how you go. Symptomatic management always with diuretics and all, they give a lot of relief. And somebody is asking, sir, can ARB is given in CKD with heart failure patient? So you cannot give both, but yes, sir, please.
So yeah, I mean, even in patients with CKD, you can start with a very small dose of ACE inhibitors and monitor the UNEs, I mean, the renal function and the electrolytes very closely.
Yes.
So that is done. But of course, you should not be using both. That would be quite dangerous.
And nowadays, ARNI can be a, sometimes better choice. So anybody wants to ask something? So there are many reversible causes of heart failure. Obviously, we cannot discuss everything today, but just go and read. They're very satisfying to see, young patients with peripartum cardiomyopathy, stress cardiomyopathies, thyrotoxicosis related cardiomyopathies. They recover so quickly. So if you diagnose it in time, so you will be quite changing the whole course of the disease. So these things we'll be discussing later on. Any other question? We are well beyond time, but yes. So today, thrombolysis was the take-home message. If the patient comes within 12 hours with a STEMI, everybody should learn about it and do thrombolysis. You know the contraindications. Once you know the relative and absolute contraindications, then you can always try it in a district hospital or a secondary center as well. Starting dose of spironolactone. So 25 mg is what we say. 12 point, yes. But hyperkalemia is one thing you should be aware of. And do not start if the potassium is on the higher side.
Sure.
I think so. We'll wind it off. And it was nice having listening to you. So I'm Dr. Shraddha Ranjan. I am a cardiologist in Medanta, Patna, and my interest is echocardiography. So it was good for me to listen. Yes, I act as an in charge of non-invasive cardiology and head of Ecolabs. So we'll be meeting, sir. Sure. Sure.
And
okay.
Pleasure speaking to all these young people. And
yes, definitely.
Thank you.
Okay. Thank you, sir. Thanks a lot.